Thank you.
Thanks, Michelle. Any further public questions? There are no further public questions. So we're moving to members' question time. So there are 2 members here. Have you got any questions? There are no questions. Oh, Paul.
I was going to raise this, the same subject before Cole beat me to it. Obviously, Sandown now, Juice closed in Sandown next to the medical centre. Sandown's just left now with Boots, who just cannot cope. They close because of lack of pharmacists. They shut for lunchtimes for no pharmacists. Some haven't got a pharmacist at all. So, Sandown has lost one big chemist, relying upon a makeshift service. I know he would agree with that. So it really is an issue that it just happens overnight. They just close, no warning to anyone. But I think the urgency, as Councillor Love has said about addressing it, certainly for the Bay Area, is putting pressure on the 2 independent pharmacies in Shanklin. Thankfully, they're still going, but the Sandown situation has become critical overnight. So the urgency will be appreciated. Thank you.
Thanks, Paul. I wonder, Kate or Michelle, if we just very, very briefly explain how that system works for pharmacies in terms of how they come to provide the service for us. Is it contracted? Not sure.
Okay, do you want to? Yeah, I'll start. My understanding is that the ICB have just taken over the pharmacy contract recently, and it was nationally commissioned by NHS England. However, most pharmacies are private providers, so the Boots hide, obviously everyone knows Boots. So if a provider of pharmacy services runs into difficulties, and nationally Jahoots has run into difficulties, there's obviously very little one can do about bankruptcy and such like. And my understanding, and obviously we don't have the press in the room, I'm assuming that's what's happened with Jahoots, and that's what was reported in the national press. Obviously, the ICB are doing everything they can, but as like with dentists and doctors, one can't magic up pharmacists to come over to the island and to provide alternative services. But we've looked at those existing providers, as I've mentioned, so Gibbs and Gunnell, for example, to open late in Ryde because the pharmacist that was in Sainsbury's in Newport closed about a year ago. So we can do what we can with the resources that we have. But we'll look into that and get back to you both.
Kate, if you wish. Yeah.
Just to emphasise and recognise, pharmacy is an absolutely critical part of our local health and care system. I know that recently the Health and Wellbeing Board, I think, considered the pharmaceutical needs assessment, looking at sufficiency of provision. I think it's really important in terms of our wider pathways and support for our residents to have that first point of call and actually to be able to access some of those key services very, very easily and locally. I think about the emergency contraception services and the work that we do as part of our substance use system. Really important. So I think it's a really important question to have raised, and one that is coming up in multiple forums at the moment that I think will be important for us to land with that written response and discussion tonight.
Thank you, Kate. Thanks, Michelle. No further questions. I don't have much to say as a chair's update. I guess Kate's spoken, but what we should do is welcome Kate to this Health and Wellbeing Board. Kate is our new Director of Public Health. You know that for many years the Isle of Wight Council has been in partnership with Hampshire with a shared Director of Public Health across the 2 areas. That came to an end at the beginning of this year, or back in the summer. We were notified at the beginning of the year and came to an end in summer. And Simon, which we wish him very well and are still in touch with, moved back to Hampshire in terms of his full-time job. And we recruited Kate. I'm very pleased that we have, and she accepted the role and has been in post for a couple of months now, Kate, something like that. So we welcome Kate along and hope that the drive forward with our public health initiatives take on renewed vigour. Not that they were not being driven forward by any means, but having somebody back on the island delivering public health, just like children's services, vital for us as an island and authority. So welcome along, Kate. I don't think, is there a few words you'd like to say to the waiting masses?
Thank you for building that up, Councillor Jordan. And really just to say, I think I've met and worked with most people. Thank you for the warm welcome. I do think it's a really unique opportunity and a really important time for public health on the Isle of Wight. I think having our dedicated leadership on the island gives us a really strong opportunity now to really take action again to support those building blocks for health that are so important for the health and life chances of our residents. And I think it's really important for me to recognise how central the Health and Wellbeing Board is in providing that system leadership for those building blocks of health. And I think looking ahead at what's coming in terms of the NHS 10-year plan and other roles and responsibilities, for me, this is a really key forum, and I've been really looking forward to today as the first meeting that I've joined. I'm new as the Director of Public Health for the island. It's worth introducing, we've also got 2 consultants in public health working with us, dedicated and focused on the island and residents' needs. Nicola Dennis is sat behind today, and we've got Elizabeth Chasser, who's with us until the new year while we do permanent recruitment for the second role, who's joined online. So thank you.
Thank you, Kate. Good news for us. I've got a couple of things that Kate's helped me with, actually. So in the meeting, in this meeting, you hear a bit more about the 10-year neighbourhood health, NHS 10-year plan, the neighbourhood health plan. And we're expected as a Health and Wellbeing Board to play a key role in that plan. And it can be and should be and will be, I'm sure, a significant opportunity for us to shape future health commissioning priorities and the population health needs on the island. Just a couple of other quick things. We have been in touch with the LGA, the Local Government Association, who've offered some, find the right word, it's not exactly support, but it's support to the Health and Wellbeing Board. Kate has been talking to them directly, and I think it's a timely, with Kate coming on board, I think it's a timely moment for us to look at some intervention, some arrangement with the Local Government Association to provide some wider insight into the Health and Wellbeing Board. And they've offered support on a one-to-one basis. So we expect them to be in contact with all of you as board members and those that are not here sometime in January or before January on a one-to-one basis. And then later in the year, we are planning to have a workshop with all members that can make it and the LGA as part of that process. So that's coming down the road in the next few months. And I guess let me finally just say about devolution, because insofar as we can be sure devolution is going ahead and starting next May with the combined mayoral authority, there will be there'll be no delays to elections that I'm aware of that have been discussed, contrary to some media publications that suggest certain areas have asked for further delay. Hampshire have not asked for further delays. We have not discussed delays, and this council agreed to move ahead with devolution at its last full council meeting. Hampshire will do it maybe today or tomorrow. They have a cabinet system, so it's a bit of a rubber stamping for Hampshire. And that will allow government to create the statutory instrument, the legislation to enable devolution to take place for the Hampshire and the Solent region, and for elections to go ahead next May, and for the combined authority to start next May. There'll be a shadow authority around February that will be a non-functioning in terms of decision-making shadow board of the 4 authorities, but it will be put in place in a legal sense once the statutory instrument is passed by government. So that's going to happen. And I guess the point for us is that the mayor and the combined authority, I won't go into all of these details, but you'll hear lots about the mayor this and the mayor that, and the mayor can do this and the mayor can. That's not the case. In most, I can't say all, but in nearly all cases, decisions by the combined authority will be made by the board. And on that board will be the 4 leaders of the 4 authorities alongside the mayor. And if you read the legislation and guidance, on most decisions, 60% majority is required. So this idea that the mayor will be elected and take over in the board and start making huge decisions about our island are just nonsensical. That is not going to happen. The board will be making the decisions, and we will, this council, this authority and this island will have a voice at that table speaking for our island. So what they will have as a combined authority is a bespoke statutory duty to promote health and health well-being. And we expect that combined authority to adopt a health in all policies approach. This means health and well-being would be considered in all major decisions, whether it's transport, housing, education. They're the key initial areas for the combined authority. And we've got examples where we've taken a health in all policies approach on the island. For example, in travel planning, and we might be able to develop that further. So there is, from the outset, a recognition on the combined authority of health and well-being in the decision making that board makes. So that's me done for today in Chairman's update. Let's move on to. Are there any questions on that, by the way? Yeah, happy just. Oh, there we go.
I'm not going to mention our bet at all. Is it leaders or is it leaders and chief executives on the board? Just for clarification.
The guidance is leaders, but it's designated as representatives of the authority, elected representatives of the authority. One, probably because of the level of strategic that the leaders are probably best placed, but that's to be refined for sure. It's not the chief exec, no. That is an elected board. Yeah. Let's move on to the Health and Care Partnership and Integrated Neighbourhood Working Update, pages 11 to 20 of our paper, and we're going to receive a presentation. We don't know who from, though.
Apologies, it would have been Wendy, I believe. Apologies, to the Care Board. That better? There we go. Donna Claydon from the Integrated Care Board. Apologies, I believe Wendy was going to be kindly presenting this on behalf of Scott Redpath, who's on annual leave. I can give you a bit of a précis of what it contains, if that would be helpful. So
we're very happy for you to present that to us if you wish.
Thank you. So the Health and Care Partnership has been working since the start of the year on strengthening its policies with the terms of reference and reviewing the strategies that are taking place across the health and care system. A stock take was completed and the health and care plan has been refreshed based on the previous iteration, with the understanding that many of the key principles contained within it are still valid today, with some minor tweaks with things such as the changes towards COVID and the release of the NHS 10-year health plan. So that project has been undertaken. A final draft has been included within the papers today for your consideration. There are a few minor tweaks that have since come about these documents since its submission, with kind interaction with Kate Harvey since she's assumed her post. The amendments contained in the document that we have are very minor. The only bit of potentially substantial change would be the inclusion of the neighbourhoods policy, which is contained within the NHS 10-year health plan. Other than that, they are very minor tweaks. So we'll be looking today for your approval to proceed to printing that and making that a public document. Alongside that, we have also been working with the partners at the Health and Care Partnership to identify senior responsible officers for developing and leading on delivery plans to fulfil the life courses that are detailed within the plan, so that we start well, live well, age well and die well. We felt it was important to make sure that the plan covered the whole of the island for the whole population and ensure that particularly children had a stronger voice, so that in the previous plan is more heavily weighted towards adults. We wanted to strengthen that, and also making sure that die well was also captured because of the impact it has on the whole community when a loved one is passing. We also recognise that this is not discrete silos, that people would transition between life course stages, and it's important that the SROs will interlink with each other's working groups. These SROs have been identified, and they have also been working on identifying the steering groups that would be leading that work. Again, it was important that we didn't duplicate any existing programs of work or create more governance structures that were unnecessary, particularly looking at the capacity that we have in the system and using that more efficiently. So they've been working with existing bodies. For example, the palliative and end of life care group has been met. They've approved the incorporation of the health and care plan duties and have been working on updating the terms of reference. So that's the approach that we've been taking. Those delivery plans were discussed at the last meeting in their draft status. They are not quite yet finalised. Some are slightly stronger than others, depending on the maturity of the existing work groups that were identified. They will be continuing doing that, and hopefully for the next Health and Care Partnership meeting, they will be able to have final draft projects in place. These will be iterative, predominantly because the Health and Care Plan has been built to last and minimise the background governance work so that we can focus on delivery. So they will be looking at doing sprints and then building on those plans as we go through the life of the strategy document. Alongside this, the national government released the Neighbourhood implementation programme opportunity, which was a bid that the Isle of Wight did collectively go for, and it was a really strong piece of work of partnership engagement, and nearly all members of the Health and Care Partnership were able to participate and contribute and even sign up to the document, even though the minimum was, I think, 4 different the leading organisations that are statutory, but everybody wanted to contribute. Unfortunately, we weren't successful in the bids. Portsmouth were the ones that for the Hampshire and Isle of Wight place were chosen. However, there's been expression that we are still keen to continue that neighbourhood working, which is building on existing works with the integrated locality services and teams and the primary care networks that are already working in a quasi-neighbourhood approach anyway, and we want to strengthen that so that we can make that go further and help more people. So there is an appetite from Health and Care Partnership expressed that we would explore looking at how we could implement that locally, potentially widening the restrictive cohort, which was frailty, set by the national team, to looking at what's the island population really need to focus on the neighbourhood process and expanding that step by step. And that was a task that's been picked up by the existing neighbourhood working group. And we've asked for that group, led by Lucy Abel, to look at what resource could be required to support that work alongside the Health and Care Partnership, recognising that the Isle of Wight didn't want to set up again silos of working. We're all in the one group trying to work as a collective. That initial piece of work was undertaken, and Lucy kind of convened a small task and finish group where they pulled up together some initial suggestions about what resource could potentially be used. That still needs to be finalised and again taken to the next Health and Care Partnership meeting to nail down the commitment going forward about what resource that could be, whether that is physical capacity contributed by the statutory partners or whether there is a financial contribution that could be made. That has not yet been agreed. And I think that might be roughly where we've got to. If there's any other points the partners attending the meeting might want to add.
Thank you for that. Any comments or questions? I'll come to you after Ian. Claire, Ian, and then Paul.
Be remiss of me not to ask, because this has been on my committee's agenda as well, is on page 19, top 3 risks, and it's lack of sustainable funding, and if you could expand on Mountbatten will utilise their grant and trust fundraiser. If you could just expand on that, that's the highest risk at the moment for lack of space, and especially relating to the hospice, please.
Thank you very much. So
Thanks, Claire.
there is an element of separation between individual organisations' contractual responsibilities, discussions, engagements, which are already happening in place. I believe James Roach has been leading on those conversations with Mountbatten. That is a discrete conversation which I'm not engaged with, so I won't be able to give a personal update on those elements. However, as a system, the SROs are taking and are trying to take a more holistic approach so that they're not thinking as organisations. They're thinking as an island representative with an experience and knowledge in a particular expertise area. So, which is why Mountbatten was supported and then they put themselves forward to lead on dying well. The risk for individuals across organisations will still be there with this work. We have not yet got to the point where we're able to say we've got funding here, we've got change of contracts there. This is very much initial steps of what is the landscape, what's the situation, where are the funding gaps, and potentially look at opportunities going forward in the future with plans. I think Laura wants to pick that up.
Laura.
Just to add to Donna's comprehensive response in that place, it was recognised as part of the dying well element of the plan that there was a need to explore what other grant funding was available to support the whole system. Mountbatten have a skilled grant fundraiser within their team and offered that resource to support this work stream. So this is totally separate from Mountbatten's funding from health.
Thank you, Laura. Ian.
Thanks very much. Really interesting report and summary. Thank you. I just had a question about the neighbourhood implementation programme, because all that work that went into it, disappointing not to be part of the 43. Now, I just wondered, given that perhaps the visibility of need on the island is poor from government level sometimes, and we've seen that in the way that the metrics they use sometimes just don't work on the island. We saw that, I think, to be honest, with Pride in Place, if I'm honest, really, and structural funding going way back. What was any of that part of what didn't work out, do you think, or were there just other reasons of competitiveness and so on?
We haven't had official feedback about the reasons why we weren't accepted. However, my personal interpretation, they had the opportunity for up to 40 places on this national scheme, so the whole country could bid, and it was at a place level, so it's not just 40 ICBs, although it was interpreted that it would be likely one per ICB as the most logical approach to ensuring parity across the country. But you wouldn't necessarily know if all places within an ICB would bid or all ICBs rejected, but we took the basis of that. For Hampshire and the Isle of Wight, there were 3 applications that were being considered. 2 were very strong, so ours was quite strong, and also Portsmouth. The difference between us and Portsmouth is that they're slightly more mature in their levels of neighbourhood working from a way of presenting it. They have the Portsmouth, I think it's a collaborative association between the statutory partners, but also with their VCS sector. They have the hive model working, but they're just maybe that little bit step further along where they can present it in a more ready-made fashion, whereas we are working as more as an ecosystem together, and we've got some areas of work that we've already identified that we want to strengthen with partners in the neighbourhood working group. It's just maybe that step behind, and my interpretation would be that Portsmouth would be able to be a good example for other places in the country. So thinking more nationally rather than locally, they might be something that would be good to learn from. The good thing is we wouldn't be excluded from that learning, one, because we're placed partners within Hampshire and Isle of Wight footprint, but also it doesn't preclude us from sharing in the community of practice, so we can get access to the resource materials without some of the burden of having to attend, going nationally, travelling to attend meetings. We can just get the information, the webinars, and learning from Portsmouth and apply that locally. And I've had assurance from the Portsmouth lead that she's already conveyed our interest in continuing and engaging with the process for having that learning to keep flowing. So.
Thank you. If I just ever so quickly follow up on that, it was really great to, and cross-island collaboration's got to be well, it's a necessity. But with an IWell hat on, I'm very interested in the role of the parishes, the 33 parishes, as a geography that's useful to neighbourhood health and wellbeing consideration. And I think that's only going to get more so. And I think there are avenues we could explore to work more closely with you. Obviously, IWell is a voluntary organisation, but the use of joint committees, which are a statutory partnership between which we haven't used, but we could use. And the way that neighbourhood data is being disaggregated down to that level, and that you have small councils with powers and discretions and money who can act in the best interests of their local community in partnership with what you're talking about, feels as though it could be a much more powerful part of neighbourhood planning for health and well. Really keen to work with you.
There's definitely an opportunity there, because we understand also that there'll be future waves. They might not have the same support attached to them, but we don't know what that will look like, what the opportunities are there. So if we have the opportunity now to strengthen based on the learning we have from this initial bid round, from what Portsmouth are doing and kind offer you've given, hopefully for the future waves we'll be in a stronger position to be successful going forward.
Brilliant. Thank you very much. Thank you.
Is it in connection with that, Kate, please?
Thank you. In terms of the neighbourhood working, I appreciate the bid was submitted before I joined. My understanding is the focus on the national pilots was very specifically on frailty. I think for us on the island, the discussions I'm hearing in relation to neighbourhoods and our opportunities are broader. And what's reassuring is that actually we still have that momentum and interest in building our neighbourhood working approaches and being actually slightly freer to define the outcomes that matter most for our population and residents, and the ways of working that we want to establish that may be above and beyond neighbourhood health services, and actually capture that link with our communities, town and parishes, voluntary sector and residents in a very different way. So I see this actually as a potential opportunity. I think the pilot scheme is a good one. It's one of those opportunities that came with no funding or significant incentive, and we can still join the learning. I think to link back that question and Donna's introduction to the role of the Health and Wellbeing Board, the Health and Wellbeing Board is likely to be asked to sign off neighbourhood health plans in the future. So actually for us to have the very clear definition of what we expect from neighbourhood working for our residents, what our communities need, I think this is our opportunity to do that. And the work that's done locally through the groups and the health and care plan that Donna's described will actually eventually have to come here for sign off. So I think this is a really important discussion, and one that I'd suggest will probably come back meeting after meeting for a while until we have clear guidance around landing that neighbourhood health plan.
Can I just, sorry,
Very
quick,
quickly,
just because it's just such an important point. I just think it's brilliant to hear that. But particularly Donna's point about transition between the health stages that are identified. They're not siloed, but they're identified in the plan, and storing up very poor outcomes for young people. We're going to talk about no doubt care leavers, for example, in a sedentary population is just passing it on and worsening at every stage. So I think you're absolutely right. This integrated neighbourhood approach within our communities is something we could really be incredibly strong on. So thank you. Thank you very much, Chair.
It's okay, and thank you for that. And then it may be something that the LGI stuff, when it comes, may involve discussions around that very thing, Ian. Paul.
Yeah,
thanks
thank you, Chairman. And comments and some questions, really. I'll start with what I liked. I like the fact that this is not a massive document. For something the ICB's been involved in, it's actually written quite concisely. It's very clear to understand what the strategy is. It's clearly written in a nice way. You can understand it and pick it up and read it as the document that it is. So my questions and comments are, I don't see enough by whens in there and targets. To have a good document setting out all these work streams, to me, my working background, there should be targets in there. So you know how you're doing, how can you measure the progress of what's happening. So I'd like to see more targets in there, definitely. The three risks are the first thing that drew my attention, the end bit. Councillor Mosdale's already mentioned the funding. But the other two risks really worry me. Lack of engagement from health and social care to take up training offer. It shouldn't be a training offer, it should be mandatory training. If it's that important that we list it as a red risk, it shouldn't be take up training offer. It must be mandatory training to be completed. There's no point being there, because any training on offer, most people are going to think, well, I won't do that. It has to be mandatory to me, not on offer. And the final comment was around lack of collaboration to deliver projects across the healthcare, the health social care. One of my other conversations was actually with Kate and with Joe recently. There's so many good things on the island happening who will put barriers in the way of them collectively working together. And there shouldn't be barriers because we're all working for the same goal. Why aren't people working collaboratively together? What are we going to do about regular meetings are great, but you have to get these people on board. On children's services, I'm trying to do that now, because we shouldn't have barriers to working together collaboratively for our young people or our adults on the island. It should be we do it. So I think the risks are real risks. So that the first one's easy, the training bit. Breaking down the barriers is harder, but it has to happen, in my view. And I'd like more targets in the paper. Thank you.
Thank you. Thank you, Paul. Before I come to you, Joe and Laura, if you want to comment on that.
Just to assist Councillor Brading and to respond to those 3 points, if I may, Chair. My assumption is we're still on page 19, looking at the update around the dying well domain of the plan. In terms of the lack of engagement from health and social care professionals taking up a training offer, I wish it was as simple, Councillor Brady. We have a very diverse health and social care landscape, which is made up of independent businesses. Those independent businesses contract with local authorities, with the ICB, with health partners, or they deliver those services out of contract. And that's the point at which we experience challenges. The offer in relation to how we support people at end of life is one that is widely made, lots of training options available, but many of those organisations have their own training programmes around that, which is where we see this lack of consistency. We can't mandate how a private business undertakes their business. What we can do is actively encourage them, and that's the work that's being undertaken. In the past, the local authority and the ICB have partnered to make that training offer free, so that for business owners, they have a decision to buy their training that they want to buy, or to access free training that we advocate as being the training that as a system we require. And even that's had limited effect, because the other impact in relation to training for health and social care workers is the time they're away from doing the job. Many providers don't pay unless people are undertaking the activity that's part of their role. So accessing training when they're not delivering direct care and support can be a really challenging position for businesses to be in. So please be assured it's an area we are aware of. It's an area that's flagged as a risk because we continue to talk about it and to try and resolve those challenges. But ultimately, it's the strength of partnership working that will help to alleviate that, rather than a mandated requirement of those providers. In relation to the lack of collaboration, it's the other angle I wanted to pick up. That lack of collaboration is something that's very variable. It's something we see when pressures come to bear on different organisations and they have to prioritise their own organisation's needs rather than system-wide transformation. And we all know if we keep doing what we've always done, we'll always get what we've always got. But at certain points in time, for organisations with low staff numbers, limited resources, they have to prioritise their own business. And that's where we see that lack of ability to come to the table. Where possible, the team are changing the times of meetings, moving how we meet, trying to ensure that that collaboration can continue, and offering lots of different opportunities. And the flexibility that we see around the end of life palliative care steering group is incorporating some of those changes to make sure that we can maximise collaboration in those areas. I hope that's of assistance.
Thanks for clarification. Paul.
Quick for Laura, thank you. I appreciate that. Could we, and I get a bit about training, but as a human body, if it's free, we haven't got to do it, we probably won't do it. When I went, I would. But the question is, somewhere in the paper, in the plan, because this is our plan, isn't it, as a health and wellbeing board, could we perhaps in the plan put a recommendation to all the people involved in the plan that they make the training mandatory? I know we can't police it and we can't make them do it, But I think if we put somewhere in the plan that we'd like the training to be mandatory, it's up to them whether they do it or not. And it's still the risk then is worded correctly. But I just think we need to, in the plan somewhere, put, as a board, we would recommend the training is mandatory.
Thanks, Paul. I wonder if, like you, understand completely the idea that Laura's dealt with on mandatory training, but I wonder if there's a halfway house where the narrative could be something like an expectation to take up training. You know, it's sort of an inference that we'd like that to happen without it being a hope. And without it being mandatory, somewhere in between. I just wonder if it's that kind of narrative. I don't know. I'm happy to be
Just an expectation from the board that training does happen, however it's worded, is just something like.
Paul.
Just a point of clarification through you, Councillor Jordan. This is the Isle of Wight Health and Care Plan. It's owned by the Isle of Wight Health and Care Partnership, not by the Health and Wellbeing Board. But I think it's a fair recommendation that we can absolutely take back to the Health and Care Partnership in terms of incorporating some expectation around that. I can confirm I chair the Workforce Board that also reports into the Health and Care Partnership, and as part of the Workforce Board and the Workforce Strategy, that expectation is explicit in terms of ensuring that staff are appropriately trained, appropriately skilled and appropriately experienced, and maximising uptake in relation to free or available system training.
So I guess Councillor Brady might have spotted that the document's in draft, and therefore it might be an appropriate moment to make any change. We'll move on, Joe.
Thank you. First of all, can I say a really big thank you to Kathy and Donna and other members of the team who actually put together the new plan and went out and talked to so many people to get their views and ideas of what should go into the plan. From my perspective, I felt heard and listened to as a member of the voluntary sector, so thank you. The second thing I wanted to say is I think that the new plan talks about the life course, and I think personally that's a significant improvement from the last plan, which broadly focused on frailty. So again, thank you for listening, that we're now going across the life course. And I think that in itself, although I understand, Laura, you're absolutely right that this plan is owned by the Health and Care Partnership, essentially the governance also links into the Health and Wellbeing Board. And I think that therefore much more closely aligns to the work of the Health and Wellbeing Board. So thank you. Can I just pick up the risks that were raised? Now, obviously, those risks are very much related at the moment to the end of life work stream. But I think if you were to look at all of the other work streams and you were to look at the work of the voluntary sector, I think you would see those risks echoed through every work stream. So particularly around the lack of sustainable funding and then the impact that that has on capacity. I do want to say that although I think it's really good that Mountbatten have an excellent fundraising team and they're optimistic about their fundraising efforts around grants and bids, in reality, the external environment for the voluntary sector to get funding through trusts and foundations is becoming significantly more difficult, massively more difficult. And so I guess my comment and my question, Chair, is whether it would be appropriate, recognising that the voluntary sector is very much part of the whole system to achieve our outcomes, whether it would be possible to have a focus on the voluntary sector at some point on the agenda for the Health and Wellbeing Board, so that we can kind of highlight some of the risks to the system, but also some of the opportunities and the achievements that are being made by the voluntary sector to support the system and this plan.
Thank you, Joe. Any comments on that?
I'm happy to respond in relation to that, and perhaps a point of clarity. The health and care papers that are before the Health and Wellbeing Board today are in a draft stage. We appear to have become slightly sidetracked by one draft update for one area. And what I would say is the plan itself, and I take you to page 16 of the papers, really clearly sets out the overarching strategy, but the 4 key areas within which we're working. The opportunity for representation from the whole health and social care system, including the voluntary sector, exists across all of those work streams. So it isn't just limited. In relation to Joe's representation around the voluntary, community and faith sector, I wonder whether that is a future agenda item for this board, to give all of our voluntary, community and faith sector organisations the opportunity to address the board and to participate in some of those discussions.
Thanks, Laura. We agree on that, and we'll take that away from here and address that. Is that what you're going to say, Kate? We kind of moved through the care plan a bit here, so unless there's any further comments and questions, Ian.
Just very quick, just
move on.
don't want to delay, but just to back up what Joe was saying, fully agree. I think the voluntary social purpose mutual aid sort of ecosystem on the island is enormous. I mean, it's twice the national density, and that's on the one hand an amazing celebration of engagement. On the other hand, it's an expression of need, because core services are so fragile that you need that to back it up. So I think, as well as representation, and that's really super important, real deep integration and collaboration between the voluntary sector and the core services. And an absolutely fundamental part of that has got to be data sharing. I think the sort of multi-agency response weaknesses, which are elsewhere, I think on the agenda, is a lot of that is down to data sharing and being able to sort of collaborate around shared pools of data. Thank you.
Thanks, Ian. We will look into that. Data sharing may be a little more difficult for a number of reasons, but Laura.
Councillor Jordan, if you were minded to, there is an action there that you could allocate. Each of the statutory partners have a Caldecott guardian who has responsibility for the safeguarding of health and social care information for our island residents. And I'm certain that the Caldecott guardians would embrace the opportunity to prepare a report to come back to this board, which outlines their responsibilities and what can be done in terms of data sharing.
We are so minded, Laura. Sound like a judge, doesn't it? Please, Laura, yeah, let's do that.
Affirmative action.
Chair, if it assists, I've just updated Kate that there are 3 Caldecott guardians for the Isle of Wight Council, and she's one of them.
Thanks for that. Any further comments, questions? I'll move on. If not, there are. I'm going to move on to the Better Care Fund. We've kind of moved through both of those items there. So we need to consider. This must be you, Laura, please.
It is me, yes, and I will aim to be short and sweet in this space. What you have before you as a board is the Q1 update in relation to the Better Care Fund 25-26. This is not an unusual report to come before the Health and Wellbeing Board. I think I've now been bringing this report certainly for the last 6 or 7 years, every quarter, just to update you in relation to progress. The report takes the same format as previously for ease of reference, if nothing else, and sets out for you the current position at end of Q1. I'm asking the Health and Wellbeing Board to approve the Q1 return with no amendments. It's been developed by our Better Care Fund task team, signed off by myself and by Scott on behalf of the Isle of Wight Council and on behalf of the Integrated Care Board. Chair, if I may, there is an additional ask that I need to make in relation to the health, to the Better Care Fund that's recently come in. You'll recall at a previous meeting you approved the plans for 26-27 and delegated responsibility to myself and to Scott to make any subsequent amendments that were required as part of the ratification process. I can confirm that we received conditional approval for the Better Care Fund agreement for 26-27. We've now implemented the changes that made that approval conditional, which were based around the matrices and trajectories and the metrics. And just for the purpose of updating the board, I'd like it to also be noted that those changes have been made and that the board is in support of their previous decision to delegate that authority to myself and Scott to sign that off. So 2 asks, apologies.
Thanks, Laura. Thanks for further clarification. So any comments or questions? Great when we talk about money. It's just, we're quite used to it as councillors, but it's quite sobering money. Any comments or questions? There are no comments and questions, but what we do need to do is approve the Q1 return with no amendments. So those who can support that, would you please indicate? Are there any? Thank you. Are there any that can't support this? Any that would abstain if we had to? Okay, that's approved, Laura. And we'll move on to Safeguarding Children's Partnership Yearly Report. We need to receive and consider this report. It's pages 59 to 130. Yeah.
Good morning. I'm
Kelly,
stepping
hello,
in.
Kelly.
Hello,
Yeah.
hello there. Sorry, the bit of a mix-up in communication. So I'm stepping in quickly this morning to present the report. I'm the partnership manager for the Safeguarding Children Partnership. And then if there's any questions, I can always take them back or try and answer what I can this morning, if that's okay. Okay, so in terms of the yearly report, the yearly report is the safeguarding partners have to jointly report on the activity that they've undertaken over the 12-month period. And then as part of the report, there needs to be a focus on multi-agency priorities. So the 4 priorities of the Safeguarding Children's Partnership are outlined within the report. And then we've updated against those the learning, the impact, the evidence and the improvements. As part of the yearly report, we all have to, as kind of not just the safeguarding partners, although it's them that lead on it, or the relevant partners too, we look at what we've done as a result of the local partnership arrangements. We're thinking about how effective the arrangements have been. And so you can see within the report, there's a contribution from the safeguarding partners, but also from our relevant agencies as well, thinking about what their response within the partnership has been. We pulled out through the report some of the themes that are emanating from the scrutiny. So there's a little bit around the independent scrutineer, but there's also things like the multi-agency audits that we've done, and any learning from reviews are also included within the report. As part of it, we've done the kind of intended actions, the actions and the intended outcomes and what the outcomes have been in some of those respects, and some of the key decisions that we've made as part of a partnership. So there's like the scrutiny of the multi-agency data sets, for example, and as I said, the multi-agency audits as well. And then we've also considered within the report the ways in which safeguarding partners have sought and utilised feedback from children and families to inform the work of the partnership and as part of their influence within. We are aware that that's something that we wanted to expand on further. And one of the things that we've done this year is we commissioned an independent body to come and look at how as a partnership we collect the voice of children and families. And that's work that we're kind of progressing this year and next year, because it was a reflection in the 24-25 annual report that we perhaps need to think about how we are involving the voice of children and families within our partnership work. There's also a breakdown in how the data has been used within the report, and then evidence from national, anything that's been like kind of national reports. So, for example, we've had the national panel did a report into child sexual abuse within the family environment as one of the national reviews, and there was also a national panel review into safeguarding children of elective home education that are electively home educated. So that's also included within the report. I don't know if it's helpful to share. I know many of you will have seen the yearly report as part of the papers. I do apologise, actually. I think the one that was sent out was when it got uploaded to the website people had, in streamlining and making the file smaller, they ruined some of the design on it. So the one on the partnership website now is the updated one with the design the right way. But you can see within the report our bit here around listen to what our children and young people say. This was something that the Youth Justice Service did recently to kind of capture the voice of children and young people across the island. And it's a short video, but it's a great watch. I'm not sure if it's a good opportunity now to kind of take any questions, or if the expectations that I'd go a bit further on what's presented within the report.
Thank you, Kelly. Do we have any comments, any questions? Ian.
A really incredibly sobering read, my goodness, and just full of admiration for the work that's being done at such a high level of, you know, challenge, and really amazing. But just looking at some of the worrying points that were brought out and highlighted, like re-referrals back into the system and outcomes for care leavers, I was interested in, I think there was a kind of dry run, a kind of assessment of multi-agency working that suggested that maybe there were some weaknesses in the way that agencies and organisations were working together or collaborating. Coming back to the point Paul made about collaboration in a small place, is that something? Is that an issue on the island? Multi-agency collaboration, sharing of information, and working together towards common outcomes, and is that something that we can get better at?
I wouldn't say it's a weakness. I'd say it's always something that we'd seek to be better at. The dry run that we did, it was a joint target area inspection, and the criteria is around early help and how partners work together at an early help level. And I know that there is a desire to make sure, particularly with the Families First Partnership Programme that's coming in, that's kind of coming in this year and next year, which should be a focus, is that really looking at multi-agency work at that early help stage, so that early intervention and prevention stage, and making sure that we work with wider family networks. I was interested to hear Jo speaking earlier about the voluntary community, actually, and how much the volunteering community has a huge impact on how we work with families at a really, low early intervention and prevention level. In terms of the re-referral rate, we also did a multi-agency audit this year into the re-referral rate into children's social care, because we are aware that within on the Isle of Wight, our re-referrals rate is high. Particularly, it is higher than national. It's around 50% at the moment. So there is some work progressing around that recent, in response to that audit. And as part of that as well, we've also just done this year a partner review of the MASH, because obviously we've got our new Isle of Wight MASH this year. So it's kind of linking into that work too, and thinking about actually why are our re-referral rates higher. It's a multifaceted reasons for that, and it's trying to, as a partnership, we're trying to kind of have a collective of thoughts on how we get underneath that and how we address those. We do know that our referrals into children's social care now, our referrals into MASH are lower than what they were previously. But part of that is it's the way it was counted, where it was Hampshire and Isle of Wight children MASH before, they were counting contacts, and we are now counting how many progress through to referral. So that's kind of reflected in the report in terms of the referral rates coming down and why they look quite a bit lower in 24-25 than they did perhaps in 23-24.
Thank you.
Thank you, Chair. Just to sort of echo what Kelly was saying, I think in terms of the partnership working, it's been really strengthened over the last 12 months. I think a MASH has been a really key cog in relation to that. What it has done is enabled those day-to-day conversations around young people to be had across agencies. And somebody from the MASH comes into my daily meeting, which is really, really key. But what I would also say about one of the key bits about good partnership is about really good challenge. And certainly from my level, my counterparts in children's services, there's almost sort of like weekly conversations around areas which actually we need to focus in relation to young people, in terms of actually knowing there's a massive crossover in relation to what we're doing, in relation to what children's services are delivering as well.
I certainly support, I think, and is that Andy McDonald?
Yes.
Yeah, I thought so, Andy. Hi, Andy. So I can only just see someone on the screen, but I certainly support that. And I think the executive group with the partnership and the main board, it's a really healthy partnership in terms of challenge and support for each other, kind of high support, high challenge. And it's, it's a really great mix.
Thanks, Andy. Thank you, Kelly. Paul.
Yeah, just picking up on the care leavers point, if I can, 'cause it's a really important point. Last night, I chaired a very productive corporate parenting board, which is now, as of last night, called the Parenting and Partnership Board, because young people don't like the term corporate parents. So there's a lot listening to the young people. So we renamed ourselves last night the Parenting and I can't get around it, Parenting and Partnership Board. But a lot of talk about it, and our care leaver data and performance actually is very good, in so much as the apprenticeship board, top of their list is care leavers. the Isle of Wight Council and the NHS are taking the lead on care leavers in so much as they're almost guaranteed an interview, providing they're suitable. They're guaranteed interview for jobs. So we are taking the lead on that. And the NHS are on board with this as well. And we talked last night about our own plan going forward, our own strategy, and it is around accommodation for care leavers. And no care leaver should be in B&B. They should all be in accommodation. But that involves a bigger picture of talking to head of planning around Section 106 money going towards accommodation for care leavers. And, also we want to create, aspirationally, we want to create a safe space, a unit somewhere. Our Director of Children's Services, Kay, has experienced this in her previous authority, where a safe space is created, where there's a kitchen and a washing machine, all that sort of stuff, where people can go as a safe space if they're released from custody or they're kicked out of their family home. Somewhere where they can go, which isn't a police cell. And I think, that all rounds the focus is on care leavers, but our figures on care leavers that are neat, they're in education or they're training or whatever, is strong compared to our statistical neighbours. More to do, but we are going in the right direction, I think, and safeguarding is a big part of that. This safe space will feed into safeguarding as well. So work is going on, and agencies are working together, which is, in that respect, encouraging.
Thanks, Paul. Kate, and then Claire.
Thank you. And I think Councillor Brady makes a really key point there that actually links the safeguarding paper with the role of this board. And I think it's fantastic that we've got the paper here to consider, actually for us to be assured that the safeguarding system is in place and secure and sufficient to protect our children and young people, babies and families on the island is really important. For us, actually, I think the link that you've made with housing is one of those building blocks that sits in the remit of the Health and Wellbeing Board to provide system leadership, to oversee and really make sure we've got a safe and secure community on our island for people to be born, to grow and to develop. So I think those foundations that hopefully will reduce some of the need hitting this report are really important within the scope and remit of this board. So I'd suggest making sure that we have best start in life for our young people and the strong multi-agency work that does happen around our family hubs on the island. And I know we've got infant feeding next on the agenda as one example, but actually in terms of the joint work between health and our local authority and voluntary sector services there too, and the housing element, actually being a local place with good work and fair employment opportunities for our residents, which we know provides then the foundations for healthy growth and development and families. So I thank you for that link.
Thanks, Kate. Claire.
Thank you. I was just going to ask if Laura could come in here, because the one thing you don't want to see is, like on page 82, is number of families living in bed and breakfast and the increase. And we both went on a reasonably good site visit. And I think sometimes you need to say what good is going to look like and what is being done. So I'd like to bring Laura in, if that's okay, to say what we're doing about children living in bed and breakfast and the progress that we are starting to make. Is that okay?
Of course, I'm very happy to help, taking off my adult social care hat, putting on my housing hat. There are large numbers of projects in place to try and address the over-reliance we've had on bed and breakfast accommodation as an island for some time. That reliance comes largely from inappropriate housing stock to meet the needs of people who find themselves homeless and needing temporary or emergency accommodation. As a local authority, the last 3 years has seen substantial investment in our own housing stock and increasing the numbers of properties that we have. And that's included not only buying properties, leasing properties and transferring stock from registered providers to the local authority. It's also included supporting the development of other housing options across the island. Earlier this year, we purchased 18 units of accommodation in God's Hill to support a move from bed and breakfast accommodation to more settled temporary accommodation for families, for children, for young people. And similarly, the development at Three Oaks on Horsebridge Hill will see the local authority having nomination rights over 4 large properties to support families who've got increased numbers who currently live in unsuitable accommodation move somewhere else. So the local authority's commitment to reducing bed and breakfast is one that's well known. We've had a bed and breakfast elimination plan in place for a number of years, working through that with the MHCLG, the Ministry of Housing, Communities and Local Government. I have to pause to get them in the right order, I'm afraid. And that elimination plan was deemed successful by them, so we moved away from that. The commitment remains that no child should live in bed and breakfast accommodation, and also we should support our care leavers in such a way to access settled accommodation at the earliest opportunity.
Thank you, Laura, because otherwise you just look at that and all you can see is the headline bit that, you know, numbers are increasing, but it is good to know that, you know, stuff is being done and actually quite a lot of work's being done in the background to try and sort this out.
Yeah, thanks, Claire. And thank you for that, Laura. I think it's it's very difficult to provide, as we know, affordable homes, to build them and make any financial sense. Developers can't seem to do it privately. We as a local authority don't really build homes. But one area where we have had some success that Laura's spoken about is when you offset the costs of temporary accommodation against the cost of providing homes. Some of these, they're brand new homes, by the way, which is fantastic. But offsetting the cost of temporary accommodation gets it past our financial hurdle. And I can see, and hopefully, where we can provide even more homes, Laura, to offset those temporary homes going. And the numbers are as they will do, the numbers are falling slightly in terms of those in temporary accommodation. But it's been one of my own personal key drives for 3 or 4 years to try and get these houses and get people out of temporary accommodation, children out of hotel rooms and caravans. And we must struggle to do that. Fortunately, the costs of that do allow us more margin than providing homes elsewhere. Councillor Love would like to ask a question or comment. I'll allow you to do that, Carl.
Thank you, Chair. In actual fact, you've answered most of my questions in the comments you've just made. But I think the point is that we are not keeping up. Even though we're doing quite well at moving forward, we still haven't crossed the line, which sees us above, you know, actually overperforming. We're still underperforming. So whilst 4 houses are wonderful, we still need to do more. And so that's all about finances, etc. And that's always going to be a problem. So that has to be the key focus for improving health and well-being, is to get families out of poverty and into proper accommodation. And that, I'm not quite sure how we do that, but that has to be the focus from that. But the point is that whilst we hear a picture of rosiness, we need to remember that we are still below the line of where I think we actually need to be.
Thanks, Claire.
So one of the things I've learned over the last 9 years is actually a lot of this stuff that we're trying to do can be blocked by not wanting to put housing in areas where we have a level of NIMBY-ishness. I'm going to say it because I don't care. No, I'm not getting re-elected in May anyway. So my problem is, and I will keep banging on about it until May, that actually we need this type of housing. And one of the things that's been really clear is sometimes speed is of an essence, because government funding comes with deadlines. And I think that needs to be expressed across the board, that the government does want to give money, but it has to be done in certain timescales. And what we can't do is take certain stuff to planning committee, etc., and then find out that it's blocked and have further delay, because by the time it comes out of the process and the bureaucracy, sometimes that, you know, that funding door has closed. So I think it's sort of a bit of a health warning really to everybody who's involved, you know, involved in that process, that, you know, this is really important and nobody wants to see a child in bed and breakfast for any longer than they need to be. I want to take away from it as well that it isn't just 4 houses, those are 4 houses for larger families. But, you know, I've got a development in my ward that is one of the happiest estates I've ever been on. And some of that is thank you to Ian Boyd, because actually Branston is what good should really look like. You walk onto Branston and it is just fantastic. So there is more that we can be done, but we need to make sure that, you know, if there is blockers, one of the things we asked yesterday at a special meeting of planning committee is to get across the real story, the story of what effect it has from a family who are in bed and breakfast, and maybe then take the story of when, you know, a family moves into somewhere like the Three Oaks development, and take their story of not just what it happens to them emotionally, but also that cost. You are talking families who can't afford to be in rented accommodation when rents have gone up to like £1,300 a month for a 3-bedroom house. You know, there are many people that really cannot afford to keep up with that rent, but also substandard accommodation where they can't afford to heat their properties or even turn the lights on because, you know, the accommodation is not as a standard. When you go to somewhere like Three Oaks and Branston and you see how well those houses are built and everything has been thought of to keep those costs down for families, so not just, you know, the affordable rent, but actually they have everything in place, from their solar panels, all the things that, you know, a family should be able to have. So stuff is being done, but what we need to do is make sure that we open the doors to it and not deliberately block it.
Great, Claire. Ian.
Yeah, yes, thanks, Claire. I think Branston is great. I mean, huge number of people involved in that, and it's a wonderful thing. But I think the points that are made are just so crucial. I absolutely agree that the general kind of narrative around housing is very negative on the island. I think it's incredibly unhelpful. But also relying on speculative open market housing with a 30% allocation that then is unaffordable even to some of the housing associations to build out is a really massive issue. And so I just wanted to ask whether you see part of the solution being, as is done elsewhere, I'm thinking about Arrington has just done its housing needs assessment, for example, the kind of parish level engagement in housing. So certainly happens on the mainland. Groups of parishes, former community land trusts, start building the houses they know they absolutely need in their neighbourhood because they've done their local housing needs assessment. Not very fast, but no. So as part of the ecosystem of house building, we kind of lack that, I think. We're just reliant on this top level, and then there's almost nothing down to ground level. Do you think there's room for us to try and develop those kind of very localised systems?
Yes.
Yeah, absolutely. And I think I'll come to you, Paul. I think I'll just repeat what I said, Ian. The financial problems of delivering housing and affordable housing are challenged nationally. We know this. You know this. So we all know this. On the island, it's no different. It's very difficult. The 80% of market rents or market price of the house is still unaffordable for many islanders, and it's a difficult problem to overcome. And build costs are outstripping the costs. Developers are finding it mightily difficult. I speak to lots of developers weekly about the problems of trying to deliver. We are trying to approach that in a way. The island planning strategy is coming back with amendments. One of those amendments will be a reduction in demand for affordable as a proportion of the total build over 10 houses. So over 10 houses, there's a 35%, 34%, 35% obligation to provide affordable homes. That's becoming undeliverable because the whole site then with the 2/3 at market rate and the 1/3 is still not making the sites viable. We are looking at reducing that. Now you might, there's a debate had, not at this board, but a debate to be had about you reducing them so you provide less affordable homes, but at least it's some affordable homes. But so we're looking at reducing that maybe 20-25% as an obligation for developers. So that might trigger some sites to start being developed with a proportion of affordables. But can I just go back to the easiest thing in terms of finances for this authority is the temporary accommodation because of the costs of it. The costs of that can be offset if we can get the financial officer to accept that, can be offset against the costs of purchasing homes to take people out the temporary and put them into homes. And that's exactly what we've done at God's Hill. On our website, I believe, Laura, we have a housing needs report and assessment. It's interesting read because the narrative often is with 1-bed or 2-bed homes. What was the first house that we bought up at Oak Farm, or nearly the first house, or committed to, or tried to buy? It's a 4 or 5-bed home. That's the point.
It is. The properties we're buying at Three Oaks accommodate 6, 7 and 8 person households, big houses.
And that's something that shouldn't be forgotten. There may not be many of those, but it shouldn't be forgotten in the narrative that we need all types of homes, and we can do it, particularly with temporary. But I'll move on because we've moved. Although it's an interesting debate discussion, because as Michelle has mentioned many times, amongst others, housing is a key part of the health and well-being of people and children. We understand that. Yeah. Laura.
Councillor Jordan, you've mentioned the housing market position statement. If it's helpful, I can provide a link to be included in the notes from this meeting so that colleagues can access that.
It's a timely reminder. It's worth a read. It gives you some facts about the position we face, not the social media position. Paul.
I know we're digressing slightly away from Kelly's report, but I think housing is a key part of safeguarding. And I think, but where it's all working together, it starts with the council. So I think probably only 1/3 of the councillors really understand the problem of young people living in temporary accommodation. I mean, corporate parenting board last night, we are all, parenting and partnership board last night, every council, all 39 of us, we are corporate parents. That's part of the role of being a councillor. And when it comes to housing, Claire used the word NIMBYism, but I don't think people really understand that if we give a young person the best start in life, get them into a proper accommodation, that will save us long term in potential care costs and other costs and perhaps getting into trouble and that sort of thing, and housing, it all starts with housing. So I'm not sure all councillors get it, let alone, we all get it because we attend these meetings. We're all corporate parents who attend the corporate parenting board. And we had a story last night from a young child who's 16. An email was read out. She basically told Kay, our director, her life story from the age of 9. And it really was heartbreaking yet encouraging to read that this child at 16 articulated in an email her journey through the care system. And a lot of that was around accommodation. So accommodation is the key to a lot of the issues. Council need to understand that developments in their area, whilst they're not popular, they generate the housing that we need to generate an active housing market as well as a first-time buyer market. Is key to a general view on the whole island's picture. But yeah, thank you.
Any further comments? There are no further comments. Well, thank you. We did receive and we did consider. We made some valuable comments, I think. Kelly, thank you for your input. Thank you for the report and the work you do. And we look forward to further updates and reports as necessary.
Thank you very much. Could I just please note, Chair, Kay Jones's apologies if she was supposed to be here today. There was a bit of a mix in communication. So if she was, yes, can I please pass those on?
Did you hear that?
Yeah.
Okay, well, that's, thank you, we've got
Thanks
that.
ever so much.
Thank you,
All right,
Kelly.
thank you, Ellen. Take care.
Let's move on to the infant feeding strategy, page 131 to 134.
Thank you, Chair. Eleanor Reid, Service Manager for Public Health, is going to join us to talk us through the infant feeding strategy that's been developed.
Hello, everyone. There is a link into this embedded in the paper. I hadn't realised that other people's strategies were sort of part of the papers, but hopefully you've had a chance to have a look at it. So really the paper's just sort of setting out and introducing you to it. It's a strategy that's been put together in partnership across Hampshire, Isle of Wight, Portsmouth and Southampton by public health teams, but also the Public Health Commission services and also the NHS maternity services, along with early help and voluntary sector family support services have sort of collaborated in terms of the content of it. So it very much fits in with the Family Hubs work that we in public health are doing with children's services that's very sort of successfully becoming firmly embedded. Public health have taken a lead on the infant feeding strand for this, and we've received funding from the Department for Education. So this paper is particularly about the infant feeding strategy, but it needs to be sort of taken into the context of the fact that we're doing that as part of the Family Hubs work. We've received additional funding to enable us to do that, and it's very much been a partnership approach. It's not just been something that Public Health have done, but we've taken that sort of responsibility in terms of that leadership of making things happen. So the infant feeding strategy was being put together more or less at the same sort of time as we were sort of developing the our plans for the implementation of the Family Hubs funding. So they required us to do a delivery plan, and very happily, they're very, very similar. So although the strategy is very recently published, we've actually made huge progress in terms of delivering on it already. So I just want to sort of highlight some of those aspects and why infant feeding is an important thing for us to be considering. I'm sure you've heard before about the idea of the start for life for children and those first 1,001 days, and obviously how children are fed in that time is a key aspect of that. The strategy is for all infant feeding, so that is either breast or formula milk that's fed to babies, and whether that be through bottles or directly, whatever mechanism. But there is a focus on breastfeeding because the evidence tells us that that's where the greatest sort of health benefits can be got, but it's not exclusively about breastfeeding, which is why it's called the infant feeding strategy. I thought I'd just sort of clarify that for you. So there are a clear vision. So that is that infant feeding is recognised and valued for the contribution it makes to the health and well-being, as well as its role in forging close and loving infant caregiver relationships. Creating a safe and healthy infant feeding culture throughout Hampshire and the Isle of Wight through supporting choices which optimise the benefits of infant feeding. It's not just the nutrition of the breast milk or of the formula, it is also the time that's spent, it's the communication that happens, it's the safety and connection, which is also really helpful and essential actually for the development of babies' brains. So there's a lot of breadth to what this sort of covers, and also breadth to the reason why we've taken such a focus on this for the last couple of years. So there's obviously people have been feeding their babies for since the beginning of time, but so you might ask why we'd need a strategy around it, and that is because actually there are things that we can be doing as part of our system that can actually support parents to be able to do so more successfully, and that there can be challenges around it that parents face that can be a bit of a struggle. And so therefore, with a strategic approach to how we do that, we can support families to have a great start in life. And we decided that there isn't just one thing that needs to be done or can be done. There's a wide range of different things because there are different issues for different families, and that we need a wide range of support to help. So the aim was to create a positive infant feeding culture. So, you know, the idea that babies are welcome and that a key part of a family, and that being able to stop and feed your baby when they need that is a right of parents to be able to do so. And so therefore that sense of how that might work in our community with local businesses and things like that, and campaigns and all of that kind of thing is part of that. To be looking at healthy and safe processes to enable parents to be able to do that, and to ensure that what we do is evidence-based, and that we're trying to focus on a reduction of inequalities, which you'll know is what public health like to do. So very much this strategy is evidence-based, as is the work of the delivery plan of the infant feeding strands. So that sort of, we had quite a lot of clear, I guess, direction as to what would be the right things to put into the strategy. We've also done quite a lot of work of getting insights, of talking to families about what they feel the issues are, and that's also been really helpful in terms of steering some of the work that we've done locally. The other thing that we do is we really closely record the data, collect the data, so we know how many babies are, how they're fed at birth, and then at the key times that health professionals, either midwives or health visitors, are seeing families, and then we make national data returns. So the key one is initiation, so that's the first feed, and then also at 6 to 8 weeks. And in that time, we've seen in the last few years, we've seen a real increase, which is really good. One of the things the strategy did point out was that the Isle of Wight was seeing a more significant drop-off. So that is from when the babies first feed to then how many were still breastfeeding or had switched to formula by 6 to 8 weeks. We were seeing much more of a change. So that is something we're certainly aware of, and look at why that happens and at what point that happens. So some of the things that we've brought in are very much to focus on that. We sort of know that at day 3 that's more likely to happen, and so we've put in place resources where there are more direct follow-up and sort of targeted support on the end of the phone and home visits and things like that weren't in place a few years ago. So we have really sort of used the data as well as what parents are telling us in terms of sort of planning for what to do on the way forwards. So the strategy also described how the work that we are doing across the whole area happens at community level, service level and civic level. And I think that's just sort of describing that, you know, really sort of small community up to sort of bigger organisations. We've got to have approaches that sort of that do that, and the interface and the partnership working is absolutely key. So the next bit I was going to talk to you about, I've talked a bit about the data. So in terms of what they are, we're now achieving 57%, and that's been consistent for the last 3 quarters. So I've been doing work in this area for many years, and it wasn't unusual to see it in the sort of the 30s to 40%, and for it to fluctuate quite a lot. And that would sort of come down to us sort of saying, oh, we've got quite small numbers of babies being born each month, and obviously there can be some variability in terms of what parents choose to do and things like that. We're seeing really consistent, and it's been almost the same for the last little while, but that has sort of focused our attention that we can get up into the early 60% is our goal now. We're also seeing the initiation rates have gone up to 81%, so we've seen increases there. So really it was just to sort of see whether or not you've got any further questions and whether you would accept this strategy as part of our overall approach to supporting families on the Isle of Wight.
Thanks, Eleanor. And thank you for the report and the strategy. I know you've been working on this many times. I was asking if you're still doing the mother-baby groups that I attended many, many years ago.
We had a pause. We had a pause for a few years where it wasn't a key focus. And I think that's what shows that this sort of thing with a key focus, we can quite rapidly see an increase in results.
There.
Thank you. And we all love a good strategy, don't we? But actually what we need to do is make sure that this stuff is put in place and support is given. I was involved about a year ago with a young person who had a baby who just was completely overwhelmed with everything. And when you're completely overwhelmed, it's really hard to, one, say what you need and, you know, get the support you need and know, you know, down to GPs and stuff like that, but actually everybody is really busy and everything seems to have a time linked to it. I'm very lucky that I've got a friend who was very involved in feeding groups and stuff like that, and I put this young person in contact with them, and she came for about 6 months like her surrogate mum, and I still thank her to that day for the support that was put in place. But actually I still, I think it's all very well having a strategy, but we need to actually track that young people's, when they're having, especially when they're quite young and having a baby, that they are getting the support in place and they're being able to ask for the support. Because this is all very well, but when you have a screaming baby at midnight and you don't know where to go or how to, to get a baby to latch on and stuff like that, you need to have some sort of like more sort of maternal support. So this is all very well as a strategy, but I actually think we do need to track some of those cases and actually see where the gaps truly are, because it's all very well saying we do something, but we need to ensure that it is being done, because this is where stuff like this falls over. Thank you.
There. Do you want to comment on that?
I think what is quite exciting about this is that we have mapped the things that it says in the strategy to what we're actually doing, and about 90% of it is in place. But I will say, obviously, there will be some cases where people aren't able to sort of join the dots and connect what's happening. So one of our aims for next year is focusing on young parents and where there is, I guess, greater inequalities in place, because what we're focused on is trying to produce something that works for most. And so, yeah, a more targeted approach is something we're focusing on. But there are definitely things out there and in place, whether it be in family hubs. We've also got an app. We've got loads of information on websites. There is a drop-in that happens every single day from Monday to Friday. There are peer supporters. There's people on the phone in maternity, and we've got a duty line with health visiting. You can ring up and then someone will come out to your home. So really unfortunate that person fell through that, because actually it's quite a broad range of opportunities to pick people up and find the way that is going to work for them. But I recognise that can sometimes happen.
Paul.
A very quick question, actually. I assume this funding is unlimited, or is it time limited?
No, it is time limited. So we're in the final year of this grant, but we have been told that there will be a new grant for family hubs, because this is, the government's decided it is a successful programme. It's going to be rolled out nationally, but we haven't been given the details yet as to how it's to be spent. So it's ring fenced, and they're actually very specific. So we had to put in a plan to say how we were going to spend it. And some of the things that we suggested, they said, no, that's not what we want. One of the examples was around transferring children onto solid foods, that sort of idea of weaning, and they were like, no, this is about the milk aspect of it, and they really sort of focused us on what we needed to deliver on.
Thanks, Paul. Thanks, Helen. I mean, as you mentioned, it wasn't so long ago, 1 in 3, 30%-ish. You're over half, and you've got a target of 2 out of 3.
Yeah.
It seems to be going in the right direction. I guess my question would be, what are the inhibitors for the other half or the other third if we get to the 2/3? What's the inhibitors for mums to
There's
not
quite a long
breastfed.
list, but on the whole, most women are stopping breastfeeding before they want to. So obviously, people have got their choice as to how they want to sort of live their family life. So it's support at the right time and in a sort of a consistent way. And so there just needs to be more of that. But also some of it is around societal expectation of what is convenient and acceptable. You know, people want their babies to be settled, and sometimes it's sort of felt that, you know, babies who cry is a difficulty, and people think that maybe formula might help with that. But what we are seeing is a lot more mixed feeding, so people doing a bit of both, and that's becoming something that professionals are fully understanding a lot better as to how to help support families to be able to do that. And that does come as part of our data. It's not just exclusively, it's any. And so I think it's about giving families more choice as to how to achieve more breastfeeding for longer. That's sort of our goal. But it's ever thus in terms of the issues that are reasons. It's to do with support, and it's to do with what people expect.
Thanks, Eleanor. Just I'll come to you, Ian. And then just finally for me, how are we doing compared to other areas of the country? Have you got those kind of data, that kind of data?
We weren't doing that great in the past, but we're doing much closer to sort of the national average now. Yeah.
Thanks, Ian.
Yeah, thank you. Thanks, Eleanor. It's really fascinating. And it's I think I just thought of the discussion about welcoming environments and cultural shift, and it really made me think about infant nutrition. You know, just back to what Donna said, you know, just the beginning of that process of transition and handing problems or benefits on to the next thing. And where we've got the food strategy group, and we've got the poverty group, the poverty data group, and I feel now much more motivated to understand and to bring infant nutrition into those discussions in a way I don't think I had before. And do you think we need to?
Yeah, there are definite overlaps with that. So there's another programme called Healthy Start, which enables families to have vouchers that they can spend on milk and fruit and vegetables if they are of a lower income. And that's available during pregnancy and whilst they have young children. And the food pantries are really keen to work out how they could either be Healthy Start receivers, so some of that money so they could buy through the pantries, but also how could they ensure that families are registered, because we know the uptake is only about 60% of those who are eligible are actually taking it. Partly because it's a bit of a clunky, difficult online system for people to do, and it's a nationally run thing as opposed to local, so there are some issues around that. But also, you know, there's sort of the idea that that yes, in terms of cost. So we're also going to be looking at an emergency formula pathway going forwards, because sometimes families get to a position where they sort of think, what we really don't want is for them to be diluting their formula overly, which can happen when people are feeling a bit desperate. So we're trying to sort of work out ways of enabling families to be able to make the right choices for their children in that way. And then you sort of talked about the community venues. We've now got over 200 local businesses and attractions, ferries, buses. You might have seen the logo, which is sort of pink and yellow and blue, of a person holding a baby. And that's to indicate that babies are welcome and that you can feed your baby in that space. And we've got a lovely video on our website whereby several local businesses took part in sort of talking about how positive it's been for them to be able to take part in the training, but also to have an understanding of the legal position around the fact that women are allowed and able to breastfeed and can't be asked to stop, etc., and how that places them as a business, but also seeing the benefit of actually attracting families. So that's a really nice sort of thing we've got, and people can go and see. So we've done quite a lot of really positive campaigns, and there's been stuff on the radio and all sorts. So that whole sort of just building up that sort of feeling that you know, this is a positive thing to do.
Just finally for me, any links to do we have any evidence or links to deprivation in terms of breastfeeding?
Yeah, we do. So we know that the most affluent families are the most likely to breastfeed, and the least affluent are the least likely. And we also know there's a link to smoking and pregnancy as well. So parents who've smoked are less likely to breastfeed. So yeah, it's a really clear correlation. We haven't looked at it in this round, but last time we really had a big focus on breastfeeding. We actually found that the interventions that we had the greatest impact on those who were the most deprived, so that what we did kind of didn't matter so much to those who'd firmly decided they were going to breastfeed anyway. They were going to find the support they needed. But for those that that weren't sure and didn't know how to access the support, additional support was what made all of the difference. I would suspect that's the same, but I think as part of our evaluation, we really do need to look at that.
Are we, any further comments, questions on this? Again, thanks, Eleanor, for this work. Kate, please.
Never missing an opportunity to weave in reference to the data. I just wanted to note that we have some lovely charts around breastfeeding on the JSNA, so the Joint Strategic Needs Assessment for the Isle of Wight. That is now an Isle of Wight focused Joint Strategic Needs Assessment, which is on the council website. So perhaps we can include the link in the minutes that go out. And in terms of our England comparison, the charts show very clearly us having been way below the England rates on the island and actually having increased and joined that gap. So I think there's been some fantastic progress, and that focus on inequalities is the next step.
Right, it's mentioned here numbers of times. The JSNI is a remarkable piece of free information and data that again is as accurate as it can be and offsets all of the social media narrative around certain things that seems to happen more and more often nowadays. That data is an access for anyone, public, us as councillors, and it's invaluable, absolutely invaluable. So it's very extensive. I know many of us know about it, but it's, thanks, Kate, for reminding us once again. Let's move on to finally to our work plan. We do, if there are any comments, that's our work plan laid out. It's page 135, agenda item 12. We have some standard things: shares update, health and care partnership update, better care fund update, and our work plan. There's some statutory items and then other items. And of course, if there are items that require this board to look at, they just need to be fed into us, and we'll consider putting them on future agendas. Any comments? You're all happy with the work plan how it is? Yeah. Well, Kate.
Yeah, that was going to be my point. In terms of the input from the LGA to help us as a board be really clear on our added value on the Isle of Wight, and they have offered to come to and use part of the January meeting for a board member workshop to really look at some of that feedback and help us develop in our joint work. So really noting that for the work plan and asking if board members are happy to consider that. The January agenda is fairly light, and at least one of the items that I'm leading can be deferred and will be more valuable to talk about later. So it feels like that could fit very well.
Thanks, Kate. And there's an admin that needs, the LGA needs to go on our full work plan. Thank you. Any comment? No further comments. Well, look, it's 11:14. We've had a reasonably interesting and informative meeting. Thank you all for your attendance, your attention and your contributions, and we'll see you in January, if not before.